Wonderful. Well, good evening again, everyone. It is a pleasure to virtually meet all of you. I want to start by thanking all of you that are joining us tonight or this afternoon, depending where you are, for this great webinar. I am Fred Marcel. I am the CEO and founder of Cube Innovation. We're the company that collaborate with Dr. Trang for putting this webinar tonight together. So I'd like also to say thank you to our partners and distributors who helped us as well to invite all of you guys for this really informative webinar on Botox tonight. So tonight we're going to be using the platform Zoom, and during the presentation we ask everyone if you have any questions to press and use the Q&A button. So that's going to be at the bottom of your screen. You can click on that and you can write all of the questions you have for Dr. Trang. We're going to try to answer as many questions as possible during the webinar, but most of the questions will be answered at the end of the webinar. Furthermore, everyone will be receiving a CE certificate after the completion of this webinar. You can expect that CE certificate to be getting to you next week by email. So please check your spam folder. Sometimes we do get in there and you don't really see it in your inbox. Tonight also, we're going to be using poll questions to make the presentation as interactive as possible. So whenever you see a poll questions, it's going to pop up in front of you in the middle of your screen. You can submit your questions, your answers, and we will discuss the results together with Marianne, who is going to be working with us tonight, and Dr. Trang as well. Also, at the very end, during the Q&A question section, if you do have any questions or you'd like to directly discuss with Dr. Trang, you can just raise your hand and we can let you unmute your microphone and have a direct conversation with Dr. Trang. So without further ado, I will be presenting Dr. Trang, who actually has been a client of us for over a year now and has been generous enough with his time to put together this really great presentation on Botox. I'm very excited for him to present all the clinical cases he has for you guys tonight. So again, welcome, Dr. Trang. The stage is yours from now.
All right. Hey, can you hear me?
Yes, wonderful. We can see you and we can hear you.
Perfect. Once again, share screen. There you go. All right. Okay, so how many people do we have?
We're already over 100 people with us at this point. We're expecting several hundred, so we're very excited for this webinar again tonight.
Wonderful. So a little bit about me is, so I'm a private practitioner. I'm a general dentist. My practice, we focus mainly on dental implant and aesthetic dentistry. And I also am a clinical faculty at UCLA Center of Aesthetic Dentistry. In there, we emphasize a lot on cosmetic versus aesthetic. So cosmetic usually implies there's human touch to it. And I call myself an aesthetic dentist. And what I do is I do dental and facial aesthetics. So the goal is to always create something that's natural looking. So we have, in this case, obviously for you to be a good dental aesthetic, good aesthetic dentist, you need to have a great lab partner. In this case, I work with Ryan Lim from Natural 8. We basically is a combination of lithium disilicate veneers, crown, non-prep veneers. And the goal is to create something that looks somewhat natural, improve the patient's overall smile, and give something like this. But my real drive is not to just take care of teeth. The real drive here is to create, make an impact, change somebody's life. It's always challenging, and whenever you can make an impact like that, it's always very rewarding. So the challenges of being an aesthetic dentist is, first of all, we have to meet our patient's expectation, and this is not something that's always easy, right? We have to create something that's harmonious and natural. that's consistent with a patient's personality, the social status, the projection that they want to provide, and their age. So, but when we are designing a smile, what we tend to do is we try to create an optimal smile for the patient at that specific time. My question is, Fred, can we put on a poll question here real quick, please?
Absolutely. Marian is going to launch the first poll question.
I would like to know what is the average age of your smile makeover patient? And
so
the second question I would like to ask as well, if we can put it at the same time, is how long do you think your dental work lasts?
So wonderful, Dr. Phong.
Yeah.
We're going to start with this one for now. We can't do two at the same time. So we're just going to give about 10 seconds for everyone to submit their answers. And then we're going to be sharing the results, and we'll let you discuss the different options.
Absolutely. So I'm going to continue because we have a lot of things to go over. So usually for me, my patients like at least starting. Oh, thank you. Yes.
You see the results? Perfect.
Yes, perfect. Yes, between 30 to 50, is what I see as well. So now the second question is, how long do you think your dental work will last, right?
So yet again, we're going to give about 10 seconds for everyone to answer, and we'll look at the results right away.
Yes, please.
Few more seconds. We got about 75% of the attendees that answered.
Funny thing is, like when you're waiting, time doesn't seem to move fast enough.
Wonderful. So let's look at the results.
10 to 15 years. Great. So when 15 years plus, 5 to 10 years, I have seen when I first started, I got a patient that was referred to me, and she had veneers that was done way back when, but it lasted over 20 years. So as I was saying, the problem is this: when we are creating a smile, we are making for the patient at that age. Our dental work does not age. The patient face age. And we age most when after we hit 50s, especially women. So then our aesthetic work would become a cosmetic work, because there's gonna be a disconnect between the smile and the face. And that's what got me started into immersing myself into the whole facial aesthetic. I wanted to learn how to use Botox. I wanted to learn how to use fillers to be able to make a bigger impact. Because if I can create a beautiful smile and bring the patient's face back in time, then I would be able to keep it for as long as possible. But it doesn't have, once you have the aesthetic, facial aesthetic thing going on, it just, teeth alone, I mean, sometimes it's like putting a nice pair of lips in somebody will also change that person's appearance quite a bit. Once again, aesthetic, not cosmetic. We want something that look natural, right? This is right after the injection. She was still swollen a little bit. But this is the challenge of dental and facial aesthetic, and that's what makes it very, very rewarding for me. This patient came in. He was not happy with the asymmetry of the face. What we did here, we did fillers on the chin, on the jawline, on the cheekbone. And also, if you were to pay attention to the temporal fossa, there was some volume loss. So by recreating the stuff, I want you to pay attention to how the eye changes. Take a look at the eye here, level of the left and the right eye, and see by providing the proper supporting tissue, we are able to balance it out quite nicely. And another thing here, making my life beautiful, I guess. Lips, chin, cheekbone, jawline, Botox, of course. So, but today we're gonna be talking about mainly Botox. So we're not talking about fillers. And funny thing is, when I first started with the home facial aesthetic, the idea is thinking about aesthetic, getting rid of the wrinkles. But as time goes by, I have found that I am using the majority of my botulinum toxin as a way to, in combination with my dental implants, with a way to help with the TMD. Also, that's what I'm going to be talking about. And I'm going to also say how I can increase the occlusal force using botulinum toxin. So can we have a quick question? Fred?
Absolutely, yes.
If we can, I want for the next few slides, I was about to go over what is Botox and how it works. Now I just want to know what is the level of understanding of our audience regarding Botox. I don't want to waste people's time because there's a lot of things to go over. But at the same time, if the understanding is not there, I would like to go ahead and spend a few minutes on this. So,
wonderful. So Marian, exactly, perfect. So the question is, currently, are you using Botox in your practice? So let's see, Dr. Phong, if you're one of the few or one of the many.
I just want to know whether I need to go over how Botox works and what is Botox, a long history about it. If people are not know about this stuff already, we can just cruise right past it.
So most people actually are saying no, and they're thinking of starting soon.
Okay, very well. So yes, I am using it. No, not so. Wow, we have interesting. All right, so Botox was first discovered with as a form of food poisoning. There are 8 serotype actually from A to G. There's 2C in there. They all have different biomechanical, pharmacological, and immunological properties. The 2 serotype that we use in medicine and cosmetic is serotype A and B. And the most widely used is the drug trademark as Botox. So Botox was first heavily investigated by the military where after World War II, we tried to use it as a biochemical weapon. And Dr. Alan Scott in 1980, he was the first one to use that to treat people with lazy eyes. That was the first thing that, so I do have a few questions that some people ask me is, because Botox is the most potent toxin, the deadliest toxin known to man. So what is the potential side effect or the risk of Botox, right? So it's extremely hard to accidentally kill somebody with Botox because you need basically 300 units of Botox per kilogram in order to kill somebody. So if the average person is 70 kilograms, right, you would need like 210 vial of Botox to kill somebody. So that would make it a very, very expensive accident. So onset and duration, there are 3 main major botulinum toxin here in the US. The first one is Botox, second one Dysport, and Zolmin. They all take up to 2 weeks for it to work fully, and they all last anywhere between 2 to 5 months. Okay, so the onset for Botox is usually up to 3 days. Dysport acts a lot faster, 24 hours, and Zolmin takes about 4 days. Storage and reconstitution. Storage for both Dysport and Botox is recommended to be refrigerated between 2 to 8 degrees Celsius. And Xeomin is the one that you can just leave it at room temperature under 25 degrees. So reconstitution recommended by Botox, the manufacturer Allergan, is for 100 vial units vial, you use 2.5 cc. Now, my recommendation is depending on the intention of what it is that you're trying to do. If depending on the size of the muscle, because what happens is Botox work locally, it doesn't spread. So it spread with the volume of saline that you use. So the smaller the volume you inject, the lesser the spread. The bigger the volume, the bigger the spread. So if you want to be very precise, you want to use as little volume as possible, and therefore the reconstitution, you want it to be much more, not as diluted, much more concentrated. So this is how it works.
The presynaptic neuromuscular nerve ending contains membranous vesicles prepared to release its stored neurotransmitter, acetylcholine. Neuronal stimulation initiates a cascade of events that leads to the fusion of the neurotransmitter-containing vesicle with the nerve membrane. This process is facilitated by a group of proteins comprising the snare complex. The membrane fusion results in the release of acetylcholine into the synaptic cleft by a process of exocytosis. The acetylcholine diffuses and eventually binds to receptors on the muscle, leading to muscle contraction. Botox, botulinum toxin type A, consists of a heavy chain of 100 kilodalton and a light chain of 50 kilodalton, making up the 150 kilodalton core type A molecule. The toxin is protected by accessory hemagglutinin and non-toxic non-hemagglutinin proteins, yielding a uniform 900 kilodalton complex. This illustration shows a cross-section of the spine with a motor neuron extending into the muscle and a sensory neuron extending out of the muscle. After injection of Botox, it would be expected that most of the neurotoxin would remain at the injection site. The Botox core molecule dissociates from the accessory proteins and targets the nerve endings. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain with an acceptor on the nerve. The Botox core molecule enters the nerve cell by a process of receptor-mediated endocytosis. It is the heavy chain that contains the binding domain. The toxin is now contained in a membranous vesicle inside the cell. Soon after, the light chain is released into the cytoplasm of the nerve terminal, where it begins to cleave one of the snare proteins. In motor neurons, the light chain of the Botox core molecule blocks the release of acetylcholine by cleaving SNAP25, which is an essential component of the snare complex. When acetylcholine cannot be released, muscle contraction cannot occur. In sensory neurons, the light chain is believed to cleave SNAP25 by a similar mechanism, thereby blocking the release of neuropeptide neurotransmitters and inhibiting the sensitization of pain nerves. The toxin does not appear to affect the conduction of electrical signals along the nerve fiber or the synthesis or storage of acetylcholine.
All right, so that's how Botox work.
Dr.
So,
Phong, I believe, I'm sorry to interrupt here, but I believe we do have a poll for the implant section of the
yes,
presentation.
please, let's get it, put it up.
Wonderful. So the question is, are you currently placing implant? We'll give again 10 seconds for everyone to answer and look at the results. Okay, wonderful. I think we're going to show the results now.
Okay, very good. So we do have a few people who are placing Olonex, and most people are placing unitary. So this here is mainly, I actually use Botox mainly on full arch, so to speak, because I feel that helps me tremendously. And for the people who are thinking about getting Olonex, maybe you might want to incorporate Botox in your treatment planning as well. So Olonex, our objective is, well, first of all, Olonex is a very expensive treatment. And along with the price tag, most people have very high expectation. So our objective is to provide the patient with the same day dentition, meaning they walk out with more teeth than they walk in. They expect to walk out with a perfect set of teeth. So our challenge is not only the surgical part, but also the restorative part. Do we have enough primary stability in our implants? Do we have enough implants to support, to do on-on-4, or do we need an on-on-6 or on-on-8 or on-on-5? So, and also we need to provide the proper occlusion. Why do we need the proper occlusion? It's because we want to control the force, right? For those who are doing on-on-X, you know that it's not a few hours treatment protocol. It's usually take the whole day. And by the end of the day, the patient's in pain, the patient's angry, the patient is drowsy with medication, the patient is hungry. And we try to have the patient open and bite and tap, 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 trying to get that proper occlusion, which patients don't always want to put up with that. So problem with that is if we don't provide proper occlusion, we have things like this, right? And you can see the breakage is right between 8 and 7. It's no fun. Patient is not happy. Sure, this is acrylic, but this here was PMMA. It breaks as well. So how can I control the patient's force? I use Botox to decrease the bite force. That way it gives me more room for error, so to speak. So how do I know who I should recommend Botox to? Obviously, we can use the facial shape to predict, right? So we all know about the three craniofacial shape: the brachycephallic, the mesocephalic, the dolichocephalic. Now, who do you think, which shape is provide the strongest bite? It's basically the brachycephalic, the one on the left side of the screen. It's well documented that they provide the strongest amount of force. So another way for me to figure out who is more likely to give me headaches is by looking at the muscle of that patient. And I'm talking about the masticatory muscle. I'm not talking about anything else. Obviously, the bigger the muscle, the stronger the bite, or at least that's the common sense, right? So here, can we put on the poll question, please? Who do you think would be generating more force?
That's going to be an interesting one, Dr. Phong. So we're going to give 10 more seconds for everyone to answer.
Can I go on while waiting for the poll, or do I have to?
Yeah, absolutely. Oh, actually, we do have the results. So.
All right. Perfect. I would guess the same as well. So here, this patient come in. He looks pretty brachycephalic to me, right? So 2 weeks before, prior to the surgical day, I Botox him up. 2 weeks later, we bloody him up and we gave him a nice set of new teeth. Patient's happy, and I was happy. Now, let's talk about this. I want you guys to pay attention to the lady. Let's pay attention to her face and see how effortlessly, and pay attention to the lower number as well. The lower number indicate the actual real-time bite force. So she's able to generate over 1,000 Newton relatively easily, right? 1,202 Newton. And this is the guy. Okay, let's take a look at his face. And he's clenching really hard, and he's done. He's done. 545. So appearance is very deceiving. And the reason why I reached out to you, Frederick, is because I needed some way to measure the force, because I don't want to work in the dark. So I think it's important to us to have some sort of guideline, because 1,200 Newton, what does that mean? 500 Newton, what the heck does that mean? It means absolutely nothing unless we have some sort of reference to it. So here, Frederick and Innobyte, they have done their own study, and they say that the normal healthy bite force of a regular, normal, healthy human being is between 650 to 1,000 Newton. Anything over 1,000 Newton is excessive force. Anything less than 650 is we have some sort of deficit. And I look up the literature. The literature I saw is some people claim is 900 Newton, not 1,000 Newton. So I take the bite force on each and every single one of my patients, and the majority of them fall between 700 to 800, you know, somewhere along that range, which is pretty nice. I want you guys to pay attention to this guy here. Let's see. I want you to pay attention to see how hard he's really trying. Let me speed up the video real quick here. Okay, give him a long break, have him bite again. Okay, he's relaxing, and come on, ready? Okay, let's go for round 2. Okay. Okay, so he's trying his best. He's trying his very best. There you go. What do we have? 853, right? So once again, we are getting something along that range. So when I have a patient like this coming in and asking for On-X, 1,500 Newton, there's no way I would do his On-X without Botoxing him up. The less force I am dealing with, the better off it is for me. So I use Botox here. In this case, is to decrease the force of mastication. This is only if the patient doesn't have any TMD or any pain at all. This is normal, healthy human being. Okay. So I'd like to talk about, if we are gonna go ahead and use Botox, we need to understand our anatomy. To decrease the biting force, there are only 3 muscles we have to deal with. The first one is the temporalis. the temporalis, we need to know the origin and the insertion. The origin basically is it originates from the temporal fossa, which is, let me see here, sorry. Okay, can I get to, oops, sorry. Okay, there you go. So we have temporal fossa right here. This is where the temporalis originate from. It's attached all the way here. This whole thing is the point of origin, right? Can you guys see this? Frederick,
Yes, we can. Yep, absolutely,
okay,
that works.
My green, the color?
Yes, yeah.
Wonderful, perfect. Okay, and it's originating from there. Then all of the muscle fibers will funnel through this zygomatic arch. Okay, and it's gonna go down and attach itself into the coronary process, which is that long thing right here. So when the temporalis contracts, it's pulling this part up by the coronary process. That's how it works. So if I were to go ahead and when I am, my intention is to decrease the binding force of the temporalis, I do not go here. I go right here where all of the muscle fibers are narrowing down. I would do 3 injections. 1, can you guys see the stars? 2 and 3, right there. Because if I were to do up here, then I'm gonna be missing out some muscle fibers for sure. By doing here, I have more of a likelihood to target all of the muscle fibers. And I would inject anywhere between 3 to 5 units per injection site. Any questions so far?
We do actually have 2 questions. The first one, I think we should address that one right now, Dr. Phong, is somebody's asking, do you extract and place same-day implants?
Yes, for All-on-X or for what?
Let me see,
The answer is
Mr. Yeah, we can come back to it maybe after. And somebody else is saying that they could not see the demo completely. So perhaps you can just scroll on the left side, the bar, which is dividing the presentation and the video to make the video bigger. You're probably going to be able to see more then.
Which demo? I'm not sure.
Just when you were working with your, I'm looking for my word here. Yes,
Okay.
exactly. Yeah.
Okay, got it. So,
sorry, one last question as well, Dr. Phong. While treating with Botox, be a lifelong treatment for the patient, will they need to continue to get injections every few months?
So that's a very interesting question. Technically, when you think about it, everything depends on what it is that we're trying to treat, right? Botox lasts anywhere between 2 to 5 months. Now, funny thing is, most of my patients, I said most of my patients, not everybody, I have only done 1 single treatment, and they haven't need subsequent treatment. I do have a few where they do need a constant routine care, so to speak, right? But once again, it depends on what it is that we're trying to do. Right now, I am doing Botox to decrease the muscle of mastication for my All-on-X. So what is the purpose of this? The intention is to weaken the muscle while the implant is healing, while the body is healing, while the implant is osseointegrating, right? So if Botox lasts anywhere between 2 to 5 months, how long does it take for osseointegration to happen? We only need 1 treatment for that specific purpose, right? So I hope it answered the question. So the second muscle, Fred, feel free to interrupt me at any time, okay? I actually like it much better.
Well, let me do it one last time here because that's a follow-up question to your last answer. The question is, does that mean that it permanently weakened the muscles?
No. The reason why it only lasts 2 to 5 months is because our body is so smart. New nerve ending will sprout and it won't regain its muscle activity. And there's such a thing as the mind muscle connection or the nerve muscle connection. The more you have control over that mind muscle connection, the faster the effect wears off, meaning your muscle and the nerves are able to reconnect at a much faster pace. The weaker your mind muscle connection is, the slower it would be able to reestablish the connection, and therefore the longer it would last. So the second group of muscle that we are targeting is the masseter. Now we need to understand the masseter has actually two heads. We have the superficial head and the deep head. Now the superficial head originate, can you guys see this?
Yes.
I wish I had better lighting. I wish I was more prepared, but so it attaches on the inferior border of the posterior border of the maxilla bone, meaning right here. Can you see the green, or should I use a different color to make it more visible?
I believe it's slightly difficult for us to see because the video is a little bit small in the quality, so I don't think people will be able to,
So how
see it well.
How can I increase the volume, the thing as you mentioned earlier? How can I?
You won't be able to do that. That's going to be on the attendee side. They can only do it themselves.
Oh, okay, perfect. Then not much I can do. So it attaches right here, right about this part right here. And what it's gonna do is the muscle fibers will project inferiorly and posteriorly and connect right into the angle of the mandible. So meaning this part right here, it goes here, right? So what it does when it contracts, it pull this up. And so it originates from here and it attaches itself all the way down here. Can you guys see this?
Yeah.
Very good. So that's the superior border. And then we also have the inferior, the deep head of the masseter, and it's a much smaller muscle. It's actually start from the medial part of the zygomatic arch right here. And what it does, it goes down, but it doesn't go all the way down here. It actually goes down around here in the upper half of the ramus. See it? Everybody can see this?
Yeah.
Perfect. Okay, so when we are targeting the masseter, we have to target both muscle. So what I like to do is I trace an imaginary line just posterior to the maxilla bone, posterior to this, a vertical line. And I want to make sure that I am staying posterior to that and not anterior to that. Is because I want to avoid the zygomatic zygomaticus major and minor, because that otherwise it might affect this patient's smile. And I'm tracing a horizontal line from the corner of the mouth, horizontally backward. And because we have the risorius muscle, it goes from here and it go backward and it interdigitate with the masseter. But it tends to be below the the corner of the mouth. So it goes inferior to that. So like everything else in anatomy, there's a lot of variation. So the risorius can be anywhere within this triangle.
I'm just going to throw out Dr. Phong, we've got a couple other questions.
Yes.
Are there any blood vessels that you need to be aware of when injecting for the temporalis? And how do you landmark to avoid them?
So great question. Botox, what we want to do is we want to inject into intramuscularly. And if you were to go ahead and film your temporalis, it's a big muscle. And we do have a temporal artery and vein, but they tend to be rather superficial or deep. So you can feel it. And I usually just have the patient clench and feel for it and just go in there. What I use, the needle that I use for Botox is the insulin needle, meaning it's probably about 8 millimeter long. So it's not deep enough to get all the way down there. And once again, knowing your anatomy is extremely important, right? So going back here, for this one, the first injection I would have the patient clench. I would go posterior to that vertical line. I feel for the zygomatic arch, and I go 1 centimeter below. The second one is that horizontal line right here. I go 1 centimeter above, posterior to the vertical line. Once again, always feel for the muscle, have the patient clench and inject there. And the last one, actually not the last one I like. So it's one I feel right at the corner of the mandible, the angle of the mandible, have the patient clench down, and I go as posteriorly as possible. Now, even let's assume that I were to hit part of the risorius, it would not affect it to the point where I would affect the patient's smile. And don't forget, we did that was only to target the superior head. And the black line right here is to target the inferior head. And this one, I want to use a longer needle. I try to go to the bone, and because that's where I'm trying to target the deep end of the masseter. Once again, 3 to 5 units per site. And finally, the third one, we are gonna be talking about is the medium pterygoid. The medial pterygoid originate from the medial surface of the lateral pterygoid plate, right here. And where it's gonna attach itself, it's gonna go find its way down to the angle of the mandible, but this stem is on the inside, not the outside. So it's originate from here, it goes down to this part. And it will also attach into the masseter. Actually, the masseter and the medial pterygoid, they share the same tendon. So those two together form some sort of sling. And that's how they pull the jaw up and closes the mouth. So this one's a little trickier to inject. So I usually have the patient turn the head on the side and turn the chin up. I have the patient clench. You guys can feel it by doing so as well. So you can feel, if you were to clench, you can feel that right here, you can feel the muscle hardening. That's the medium pterygoid. Once again, here I target one needle right here into the bone, and two. Once again, 3 to 5 units per. And that's how we take care of, that's how I decrease, I control the occlusal force when I'm doing my orthodontics restoration. So now we're gonna be talking about TMD. TMD is such, before we move on, any questions? Marianne and Fred, I'm actually expecting you guys to help me out with the questions.
Absolutely. We do have a few questions, but I believe we might want to keep them for a little bit later, as the time is kind of going by quickly.
Okay, should I speed up the time? Okay.
Perhaps a little bit, if you don't mind.
Not at all. Okay, so TMD, blah, blah. I want to mainly talk about things that can be treated with botulinum toxin, meaning local myalgia, myofascial pain with spreading, and myofascial pain with referral. Okay, so of course, when you have a patient like this coming in.
Hi, my name is Chastity, and I have had really bad migraines for quite some time. So I came in today because I originally thought that it was my tooth that was having really bad pain, but turns out it's not. I have had really bad jawline pain into my ear and up into my top of my forehead, which causes a really bad migraine. So I came in, we looked at my tooth. It is not my tooth. It is actually the muscles in my face. So the pain that I've experienced has probably been in this jaw area about a week now, but chronic migraines, I would say the last couple years, I've had bad migraines where I've had to take Excedrin, I've had to take ibuprofen 800s, thinking that maybe it was caffeine, thinking maybe it was a sugar, anything that I can do to just take off that edge of that migraine. And again, like I said, this has been happening for the last couple of years now. It's Chastity again. I am back in today for a small touch up. Last time I was here was a week ago, and I had Botox in my area that I have concern of jaw pain, muscle pain, headaches, migraines, all of the above. It actually worked. A few days after I had left the office, it started kicking in to where at night I was waking up and I would think to myself, am I clenching my jaw? Am I grinding my teeth? Because my muscle has been so used to tensing up that it wasn't actually tensing up. So I have had great sleep.
Oops, sorry. So anyways, when the patient come in with the toothache, and then we see that there's nothing wrong with the teeth, then of course, the next thing is we can do the examination and figure out what's going on. That's relatively easy to identify and treat. But what about patients who come in saying that they don't have any pain, any problem at all? So this patient came in, claimed that he didn't have any jaw pain, any problem at all. So I'm just taking the bites like I would normally do with everybody else. My dental assistant is super shy here, trying to avoid eye contact. And here, right here, what is he doing? He's raising his hand up. Obviously, while biting down, it has caused some serious pain. So do you think he has a TMD issue here? So that was another easy patient because clearly he showed pain, and his bite force, I believe, was 131 Newton, something like that, right? So when the patient display pain, it's easy for us to also evaluate, give us an opportunity to dig in further. Now let's take a look at this patient over here.
Go ahead and clench as hard as you can on the back teeth. As hard as you can. That's the best. All right. Okay.
So she displayed no pain whatsoever. She wasn't complaining about pain, but what was her bite force? 391 Newton, which is relatively low. So I start comparing.
Right here, am I right?
I want you guys to pay attention to see how much pressure I'm actually putting on. By looking at my hand and my fingers, you can see how much pressure I'm putting on.
No, it just hurts.
Okay. How about this side? No,
Not as much.
not as much. Clench again. Right here. This is how much pressure I'm putting on.
Oh,
Okay.
yeah.
And right here, right?
Yes.
Is it moving anywhere at all?
No.
No. Okay, that's good. Am I hurting you anywhere? Any discomfort here?
Yeah,
Here?
yeah,
or
on
here?
both sides.
On both sides. Here?
Yes, on both sides.
Sorry, see.
It's okay. It's okay.
Okay. So, yeah, here too, huh?
Yeah.
Okay, sorry.
So here, what I was trying to figure out is whether clearly we're having some local myalgia. I want to figure out whether we have also myofascial pain or not, right? So once we are able to identify the problem, and once we are able to identify the source of the pain and the site of the pain, is relatively easy to fix. So what I do is I figure out where the source of the pain is, and I mark it, and I inject. I usually do, my magic number is 3 to 5 when it comes to decreasing the force or taking care of the pain. So this lady earlier, you saw she was 1200. And once I was starting to do the muscle evaluation, there was a lot of trigger points. So what we do is number up, do Botox.
Clench.
So I actually like to ask patient to clench because that kind of force the muscle outward, and that allow me to penetrate into the muscle without
Clench really hard, okay?
without just instead of
Thank you, sweetie.
delivery the Botox
Alright.
in the fat or soft tissue.
2, 1, clench. 3, 2, 1, clench. Clench. All right, you all right?
Yeah.
So March 31st, she came in with 1200 Newton. A week later, she came back 923 Newton. And August 4th, I did do another session 2 weeks prior. So she came back with 612 Newton. So we are able to decrease the force quite a bit. And also help her headaches and migraines quite a bit as well. But I am noticing more and more of this. No pain.
Very good. Not yet, okay? Go ahead, bite as hard as you can on the back teeth. Super strong. As hard as you can. Ah, there you go. Perfect. All right. Okay.
Put your back of the back of the teeth and bite as hard as you can. At the back of the teeth. Go ahead and bite as hard as you can. Okay, come on, a little bit more. Bite as hard as you can. Yeah. Okay, then you can go ahead and open up. There we go. Tooth. As hard as you can. Go ahead and bite down as hard as you can with the back teeth. Bite, 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 bite. Bite down. 98. That's hard as you can.
So of these patients, I have many more, but all of them display a very minimal amount of bite force. The first guy, you can see he's a brachycephalic. And if you were to touch his jaw muscle, it was rock solid. I expected him to be able to generate a whole lot more force. But when I was doing the muscle palpation, there was no pain, no discomfort, no headache, no migraines. There's no history whatsoever. So my question is, how come they are only able to generate so little force, and yet there's no TMD, there's nothing that affect them? Let's take a look at this one over here. So I shown this video. I took 3 try, and it's very telling. Let me show this. Brachycephalic, super strong guy, 490 Newton, first try. Second try. I let him readjust the sensor, making sure that he's comfortable and he's able to bite all the way down. (315 Newton). So once again, brachycephalic, take a look at the size of the muscle, right? Clearly, we expect him to be generating a whole lot more force. So obviously, he's telling me that he's feeling tired right there. I asked, do you have any pain? No pain, but just feeling a little tired. So give him plenty of time to rest. And here we go for a third try. (192). He's done. Yep. He's not in pain. He's just feeling tired. So I'm trying to figure out what's going on here. So I'm like, are you in pain? No, no pain. Okay, so what happens here? I think what happened is, if you were to go and work out your muscle, at the beginning of your workout session, you're probably at your strongest. And at the end of the session, if you have put in enough work, you should feel pretty exhausted, right? And I think this is exactly what's going on. I think that what's going on, this is just my hypothesis, is if you are continuously on a daily basis and throughout the day, you are constantly exerting your muscle, obviously you're not going to be able to generate as much force anymore, right? So this lady here, July 8th, she came in. I was supposed to do a fitting on her. Then I realized when I asked her to open her jaw, for me to numb her up, she was able to open, not the widest opening, but then her lower lip would start to shake. It's like you can see that she was trying really hard to keep her mouth open, but she was not. So if I were to go ahead and proceed with the fitting, which was number 18, and with little minimal opening, I know for a fact that she's not gonna like me afterward, because she's gonna be having whole type of headache or discomfort afterward. So I talked to her about maybe relaxing those muscles. That way she would be able to open wider next time. And so we postponed the fitting. We did the Botox instead. And 2 weeks later, sure enough, she was able to open much wider. But I want you to pay attention to the bite force. July 8th, she was able to generate 574 Newton. After we sent her muscle to a force vacation, September 9, she was able to increase her bite force by 708. So the muscle have time to relax. So now they are finally able to regain its strength. So I think this would be a good time to stop. I think we have gone over time. Any question?
There are plenty of questions for you, Dr. Phong. So let's take a few questions here. And before we do so, we've got some comment I want to share with you, Dr. Phong, that you were really a great speaker. Several people did mention that, so I wanted to transmit that.
Thank you.
I also want to inform everyone that Dr. Phong is also going to be offering a more advanced course on Botox in more depth. So if that's something you're interested, we will send a poll questions to this effect towards the end of the presentation. So let's take a few questions. Let me see which one we can look at. So this question is, what adverse reaction, feeling, or issues patient experience and report with Botox?
What adverse reaction that the patient might feel? Well, one of the most common potential adverse reaction that you're gonna, well, first of all, the side effect of Botox, or the effect of Botox is muscle weakening. We know that, okay? So I will not consider that as a side effect. Now, with just any muscle weakening, the less you use the certain muscle, the more atrophic that muscle will become. So actually, that's why some people actually use Botox to reshape the face. So people with a square jaw, we would be injecting Botox on the masseter at the angle of the mandible to force the muscle to become atrophic and therefore changing the face. But the most common adverse effect is if you accidentally inject into the blood vessel. And it's hard not to, it's very hard to be able to always avoid blood vessel. Then you would have a bruise and or actually some sort of, it's not uncommon to have some sort of headache or localized pain if you inject in the blood vessel.
Wonderful. So the next question is the cost of Botox product. How much is it?
I have no idea.
Wonderful.
I'm just going to throw in that one that we got a bit earlier is when placing implants, you administer Botox to limit occlusal forces. Is that correct?
Yes, 2 weeks before the surgery, 2 weeks before we actually load the implants.
Okay, great.
I think there's also a few questions about C. We're going to be, just a reminder, we're going to be sending the C certificate via email next week, so you can expect them to receive them at that point.
So I'm reading Martin asked what biomeasuring device you are using. Well, I'm using the one that is putting this show together.
So let me maybe elaborate a little bit on that. The device is called the Innobyte. It's a very easy product to use, as you've seen in the many videos we have. If you do want some more information, we're going to be actually, let's pull up that poll right now, if you don't mind, Marianne, about getting more information about the Innobyte. This is just a side note, but tonight we are offering a special promotion on the purchase of the product. If you'd like to incorporate that in your practice, if you are interested to receive a formal quote to get more information about it, you can basically say yes, and we'll contact you following the webinar. Dr. Phong, did you have any other material, or you'd prefer we go through the questions at this point?
Let's go over the question. I think we've gone over an hour that we're planning on going over. I'm sure everybody else have other things to do, so I'll be more than happy to answer any questions that they may have. I saw a question regarding using filters for the black triangle. And I gotta say, it hit or miss. It's actually, it's not as, the result is not as much as you would like to have. I've done that several times, and to be honest with you, I don't do it that much anymore, and I definitely don't even guarantee that type of results for black triangle. Okay, this
I
is
have an,
has nothing to do with Botox, nothing to do with my force.
I'm not sure if you can answer that, Dr. Phong, but someone is asking, are you in California allowed to give Botox for cosmetic?
As far as I'm concerned, I don't think so. It has to be related to dentistry, such as TMD, or I think controlling the occlusion. Basically, whatever I'm talking about today, it has nothing to do with cosmetic, has nothing to do with aesthetic, and it should be part of our arsenal, being able to provide that type of service to our patients.
Another question is, should you inject into the belly of the muscle or the both originate ends of the muscle?
The belly of the muscle. Basically, remember, Botox works wherever it is injected. So the muscle usually has a wide bench, wide area where it originates. All of those muscle fibers come out somewhere. There's no way for us to target every single muscle fibers, right? So the belly of the muscle, usually that's where we have the most concentration of all of those muscle fibers coming together. And that's where I like to target.
Somebody was asking also, is it 3 to 5 units per star?
Yes, each star represents the site that I use to inject.
Perfect. Marian, I'll let you take the next question here. Oh, Marian, you muted, I believe.
Sorry. So another question that we have, Dr. Phong, is does the injection of Botox feel anything like burning or anything? And is Botox like the dermal fillers, which has local anesthetic?
No, Botox does not have local anesthetic. Can I stop sharing my screen?
Absolutely, yes.
Okay.
We actually, I just did it for you so people can see you now full screen.
Okay, perfect, thank you. I'm not sure as to what it is that I'm seeing right now. I'm seeing my slide.
You can probably just click on the Zoom icon at the bottom of your screen again, and it's
Yep.
going to bring everything up.
Wow, welcome to technology. All right, there you go, perfect. So where are we? Sorry, got distracted for a second. Go ahead, what was the question?
Nope. So does the injection of Botox feel anything like burning or anything? And does Botox like the dermal fillers, which has a local anesthetic? That was one of the questions.
So great question. So the pH of the Botox is 7.4. Is very neutral, and it doesn't feel like anything. The only discomfort is the needle coming in, and and the pressure maybe of the solution. That's about it. And it does not have anesthetic in it, but it will not burn.
In the meantime, there is a question about the use of the device as well. Somebody's asking, can you describe the patient experience? Do they like do they like getting the bite force taken? Does it impact patients' acceptance?
You know what? Most of the patients are very, very compliant. I don't think any of them have any adverse reaction. What I have found is actually it allowed me to have a deeper discussion with them, because remember, dentistry, what we do is we have to educate our patient. We cannot make the decision for our patient, right? Our patient have to make their own decision. So, but in order for them to make the right decision, we have to be able to have a discussion with them. Without that discussion, without that information sharing, is basically they tend to make the decision based on the ticket item or the price, and it's not always the best decision. So using the bite machine, Innobyte. Innobyte.
Correct. Yes.
Sorry, Innobyte is actually a lot of patients ask me, so what does that mean? What do the number represent? And this really allow me to get into a deeper discussion with them.
That's great. A lot of people are asking.
One thing, if you noticed, if I had not taken the bites, how would I have noticed that the patient who reached out his hand at 131 Newton and complained about jaw pain? How would I be able to figure out with that lady that was clearly in great discomfort when I was doing palpation on her masseter and temporalis?
I like to say you don't know until you measure.
Yeah. I mean, it's like I said, there are things that we see, such as the craniofacial shape, right? We understand a certain shape tend to generate more force. We saw those muscles. I found those muscles. They look super hard. They should create a lot of forces. However, you're gonna see people with tori or worn down dentition, believe it or not, it's like a lot of them don't generate as much force as they should be. And I really think it's due to a chronic fatigue. You constantly working out those muscles, and sometimes our body is amazing. We are so we are able to adapt quite easily.
Another interesting question I think we can address now is, why do some patients do not respond to Botox, and why does it doesn't take effect?
There are some papers that have reported that people do develop some sort of immunity over time. So, and that's why I do have some product also tend to have a lower efficiency than others. So right now in my office, I'm only using I only use Botox and Dysport. I no longer use Zoom In because I just don't have as much success rates. I tend to have a little more complication, not a whole lot, but enough for me to say I'm not gonna be using it anymore.
There's a lot of people asking if you need any kind of certification to be
state by state, depending on your dental board. I personally, I have no idea.
Fair enough.
The one thing that I just saw came up, because we hear this a bit, is their recommendation for night guards.
Yeah.
Well,
in between, yeah.
So night guard is great to protect the teeth, right? Now, if you're a boxer or your clencher or grinder, night guard will protect your teeth, but it will not change the muscle activity, right?
Okay.
Now, if you weaken the muscle, then would you still need the night guard? Now, I have no idea. I mean, it depends case by case. But night guard is a protective device. It's not a preventive device. I mean, in terms of it protect the teeth, it doesn't affect the muscle.
Okay.
Other questions here from a number of Botox manufacturers. Which brand do you prefer?
Like I said, I used Botox and I used Dysport. There's a new company that's coming out, and they are gonna send me some sample. It's called Daxify. Supposedly, it's gonna be lasting twice as long. I don't know. I cannot wait to try it out.
Wonderful. And I don't know if you know about this one, Dr. Phong, but some people are asking if there's a reimbursement code that insurance are paying for Botox.
I have no idea.
Sorry, wonderful.
I usually don't deal with pricing. I don't deal with, I like to deal with the clinical stuff, not the administrative stuff. I have
Got it.
maybe one last question again. I think you've mentioned it, but it might be a good summary here. How many units do you use to reduce the bite force pre-treatment?
3 to 5 units
3 to 5 units.
per site. So earlier I talked about temporaries. I have at least minimum 3 sites. So 15 units per temporaries. So that's 30. Masseter, let's say it's 4 sites, right? Let's say 5 units per site, make the math easy. That's 20, that's 40. That's 40 plus 30, that's 70, right?
Mhm.
And then the medial pterygoid, that's 10 units per. So that's 90 units, I guess, if my math is correct.
I believe it is. I think we've went through pretty much all the questions. If anyone still have some questions at this point, you can still submit them. Otherwise, I think we're gonna thank everyone.
Feel free to do reach out to me for any future question. I'll be more than happy to answer them. I really enjoy what I do. I really enjoy sharing with whatever I know. So don't hesitate. Feel free to reach out to me, send me an email, send me a text, whatever it is, and I'll try my best to answer, get back. Okay.
I'm just gonna
Wonderful.
throw out that we're gonna, Dr. Fong will put your contact info on our CE credits that we're sending out for everyone. I think that that would be a really great way for kind of the connection and seeing where we can have to move forward with any conversations. So thank you for that.